Respected Chairperson, a very good morning to all of you. And first of all, Prophet, I would like to congratulate the organizers of IDEC for a very good show. And I was just walking around the restaurant arena today morning for breakfast, and all of a sudden the attendant over there said, "Doctor, you should eat this. This is misal pav, which is quite native to this place." All of a sudden, I struck something like bhajia pav or something like vada pav. No sir, this is exclusively misal pav. So actually, we Indians, they look like pav is same in both of the dishes. We are more or less like the misal pav, but actually metabolically, we are like vada pav with a that big fried patty of pav in between. So we look like misal pav, but we are actually vada pav. This is something which all of a sudden struck to me. So this is actually what we are talking of. That is the Indian phenotype. That is the thrifty phenotype we had from our predecessors. There was again a lot of famines. So our body has developed this tendency to conserve, and now all of a sudden the scenario has changed. We have got everything. The moment you will open your refrigerator at your place, you will find one big dabba of mithai. The same is there for when you look for you go to your kitchen and you see Indori say, Lami say, and all those savory food which was there. When we were kids, actually this used to be cooked, this used to be prepared during the times of festivities. But now the scenario has changed. So let's talk about the Indian phenotype and in what way the scenario is changing and in what way we people are different with respect to diabetes. So the percentage of patients globally fail to achieve glycemic control, this is again the world data, is 40 to 70% of patients who fail to achieve HbA1c. And additional risk factors again, they have this 85% of them are overweight, 65% have high blood LDL cholesterol levels, 71% have hypertension, and patients with type 2 diabetes have an almost two-fold greater risk of CVD. So what is the Indian scenario? 65 billion type 2 diabetes again, and 66.9% fail to maintain HbA1c. Why such uncontrolled patients? Do we require something else in medicine? Let's look into the patient's background. So what is an Indian phenotype? The so-called Indian phenotype refers to certain unique clinical and biochemical abnormalities. That is, we have increased insulin resistance, greater abdominal adiposity. This has been talked so many times. The previous lectures have also covered this. And lower adiponectin and high HSCRP. So this is something we people are a little bit different from the rest. We are leaner, but we are fatter metabolically. So the Indian phenotype, in spite of lower BMI, Indians are having more abdominal fat, more insulin resistance, high levels of C-reactive protein, lower levels of adiponectin, high levels of leptin and triglyceride, increased susceptibility to type 2 diabetes and coronary artery disease, and characteristic dyslipidemia that has been talked so many times now in the last 2 days, low levels of HDL and high levels of LDL. This reminds me of the famous comic character Laurel and Hardy. We are actually like Mr. Laurel, but our metabolic profile is like Mr. Hardy. If you will like me to Indianize it, most of us during our childhood times must have read about Motu and Patlu. So we look like Mr. Patlu, but actually we are who? Metabolically we are fat, and this is something which is there in the Indian setup, and that is Indian phenotype. So for the same BMI, more diabetes among the Asian Indians, you see the purple line for both the genders, we are at the same BMI, we are having more prevalence of diabetes. So Indian phenotype comprehensive management is essential. This is just like the famous comic character, the Three Musketeers, the legendary character from UK again. But the Three Musketeers were there for good. They were the heroes. Now the Three Musketeers are doing harm in our Indian society. Diabetes, obesity and hypertension, leading to overweight leading to again hypertension. It's a vicious circle. So this is something which we have in our Indian outset. 8 out of the 10 persons in India are having at least a feature of Indian phenotype, and Indian phenotype patients require comprehensively. Our criteria, our management, our perception of management has to be a little bit different from the rest. So comprehensive management and current therapeutic options. This is again as per there are so many guidelines to recommend. As per the WHO, they say the HbA1c should be less than 7%. Some of the guidelines they do recommend less than 6.5. 25 should be the BMI or lesser waist circumference. Again, see these kind of the blah blah things we are seeing every now and then. Basically, what is more important is the patient-centered approach in diabetes. You need to tailor your treatment as per the requirement of the patient. Suppose I'm wearing XL, you might be requiring double XL, or you might be requiring a shirt size of L or medium ring. That has to be decided. That vision, somehow, somewhere, we need to go through deep through these guidelines, and we should make out our own criteria. So now, since this is again more of a I'll be talking more about dapagliflozin. So AAC's most recent guidelines has actually this DPP4 inhibitors are little going bit down with respect to SGLT2 inhibitors. This is something new which has come up, and as per the ACP's most recent guidelines, they have moved SGLT2 inhibitors ahead of DPP4 inhibitors. Is it a Superman or Batman story? Superman versus Batman. You must have seen that film. Or is it something like the legendary actor Rocky used to say, "Mere to do anmol ratan ek hai dusra alakh." I will say there is nothing like Superman or Batman amongst these two molecules. They are the most beautiful molecules to ever hit in the field of diabetology, and both of them are going nicely together. But today, let's have a little bit comparison between the two. And so the 5 key benefits about the treating Indian phenotype, important lever to treating Indian phenotype. We need fast action, fast onset of the time of action, significant sustained glucose lowering action across the diabetes, weight loss, again, systolic blood pressure reduction, and insulin independent mechanism. This is for SGLT2 inhibitor and other benefits. And we have got data for EMPA, now Canvas also. Just 2 days back, I also got the opportunity to talk about Canvas, and I think it is very promising. And in near future, 2018, we'll have the DAPA data also. So the SGLT2 inhibitor removes excess glucose. We all know, we have been seeing this slide so long. Actually, it is an insulin independent mediated mechanism, and there is a loss of calories. This is something which is needed when we are also aspiring for weight loss. So DAPA versus DP4 inhibitor HbA1c, see there is a significant drop in HbA1c of 1.2%. Higher we are at HbA1c levels, the more will we fall. This is the fall effect, which is there for both the molecules. So HbA1c reduction with DAPA is significantly ahead of DP4 inhibitors in 24 weeks. Let's talk about the fasting blood sugar. It is again the dip of fasting blood sugar around 31.7 with dapagliflozin and metformin. So FPG reduction with DAPA is significantly ahead. And let's talk about the postprandial blood sugar, which is again one of the major culprits. 2 hours postprandial blood sugar reduction with dapagliflozin is significantly ahead of DP4 inhibitors in 24 weeks. So DAPA versus DP4 for weight loss, definitely there is no competition. These molecules, irrespective of the 3 we have right now in the market, all of them are very good with respect to weight loss. And weight reduction with DAPA is very good. And apart from that, when you combine DAPA with metformin, offers HbA1c reduction of 1.2% with patients with high baseline. Definitely, if you are higher with respect to your HbA1c levels, the fall will be more. But the data is very good with DAPA and SGLT2 inhibitors. What we are supposed to lose when we are overweight, we are supposed to lose the increased fat mass, which is actually associated with metabolic abnormalities rather than the lean tissue mass. So the lean tissue mass is increased when you start this molecule, and there is drop in the fat mass, and this has been nicely depicted over here. So this is something which is making us metabolically healthier. SGLT2 can be given just a day back. One of the guys asked us, one of the doctors sitting in the arena, he said, Doctor, can we give it to a lean person? Definitely there is no contraindication. Basically, it can be given to a lean diabetic also who is having normal weight because it will help in blood sugar control and the other plus things are not going to go. So sustainability card, there are good number of molecules. When you start, you achieve good targets and later on you lose. This is just like what we did in this Champions Trophy. Initial matches were won and later on we lost. So this kind of activity is it there with SGLT2 inhibitor with lots of hype. Our team is the number one team and at the moment when we need the most, we lost. So this is something which is not there with the molecule. This is something which we call as sustainability and durability of the molecule. And we have got a long-term data now. And with all of the three, they are quite sustainable. They are going to stay. So the Indian data on dapagliflozin with respect to LDL-C changes, the yellow line is for DAPA. See the difference as compared to the other ethnic communities. And with changes to body weight, because we are leaner, so definitely the weight loss will be lesser as compared to the other communities. Apart from that, see the systolic blood changes. Again, it is significantly good with respect to the other fraternities. So, in the Indian outset, this molecule is looking very promising. Now we need to see where we are supposed to be watchful of, and there are some adverse events like infections. I've been using this molecule since last 2.5 years, and you need to see actually. You need to actually choose your patients. There is a big checklist and you will have to cross it out. And that is for that you will have to have a clear vision regarding what are the no's for this molecule, then can beautifully incorporate this molecule in clinical practice without any serious complication. So euglycemic decay, there are hardly 10 patients with euglycemic decay. Initial studies, most of them were type 1 diabetes. Now the data has rose to somewhere at about 2,000. But if you are beautifully combining it with a DP4 inhibitor, rationally speaking, you will not have euglycemic decay. Kidney safety, now you have got MPARAC data, you have got Canvas-R data, and the data is very promising. See the graphs of Canvas where they have shown how the trend sets from macroalbuminuria to microalbuminuria to normoalbuminuria. This is something which I have never seen. And I expect this when they will come up with their DAPA renal study in 2018. So this is something there. Bone fractures, you need to actually see the patients as per the selection, and please don't give it to the elderly who are 65 or 75 plus. So I'm falling short of time. See the cardiovascular data also. When you compare it with ALPA, again it's looking very promising, but their CV data is going to be launched somewhere around about 2018. So Dr. Mangesh Srivastava is there, so the giant will be talking about something, the real CV data. So I will not tell this thing. And so let's see. I will like to. There are safe data with respect to no increase in heart failure, because after TB, support TB, we were made to prove each and every diabetic drug has to prove whether it increases CHF or something like that. So all-cause mortality, primary illnesses, again it's looking very promising. So to summarize, Indian phenotype makes us metabolically unhealthy with leaner weight. Indian diabetics are having their own challenges, and SGLT2 inhibitor finds a special place in Indian scenario. So and DAPA has been demonstrated in randomized controlled trials to result in HbA1c lowering, weight loss, and blood pressure reduction. So the multiple benefits and cardiovascular profile of DAPA are reinforced by the data in the real world clinical settings, further supporting the early use of SGLT2 inhibitors in the treatment paradigm of type 2 diabetes. With this, I'll end my talk. Thank you.
Thank you, Doctor.